Seasickness by Dr. Louis van Heerden, performed by Dr. Frans Cranier. What is seasickness? The French call it mal de mer, but seasickness by any name remains at best unpleasant. Another term frequently and used interchangeably is motion sickness. As we can all appreciate, you don't necessarily have to be on the sea to suffer from this condition. Most people at some stage of their lives will suffer from motion sickness unless they are insensitive to motion, which has its own complications. According to literature, people suffering from motion sickness can broadly be divided into three groups: those who are highly susceptible, those who will only have symptoms under rough conditions, and those who will only get sick under extreme conditions. It is said that motion sickness is a rare condition before the age of 2, and that it peaks between the ages of 3 and 12, and thereafter it steadily declines to actually be rather rare after the age of 70. Now you might be asking quite casually what motion sickness is, as if you as a diver never suffered the indignity of feeding your breakfast to the fish that appeared out of nowhere as you hung over the side of the rubber duck on your way to where you'd hope it would be a life-altering experience under the sea, on your way back from the distant memory of what you did before. And it suddenly becomes clear what the dive master meant by purging is optional. Oh, that peculiar tingle in your stomach that you thought was butterflies, first trying to suppress it with subtle yawning and then later swallowing as you start drooling, with beads of perspiration on your upper lip and your pale face now becoming quite noticeable, building up to that single moment where all grace and elegance are thrown overboard, literally. Yes, my friend, you've just vomited and experienced the condition firsthand. Vertigo is very similar to motion sickness in that both are caused by vestibular stimulation. It is widely recognized that motion sickness is caused by unusual stimulation and conflicting information or a mismatch between the sensory systems. However, this cannot explain all cases of the condition, and another theory may also link it to a decreased ability to actively control the body's positioning. Motion sickness may affect a diver in two ways. Firstly, on the boat, mostly on the way to the dive site and once on the site, or on the way back from the dive site, which occurs somewhat less frequently. Secondly, it could also occur underwater, usually when doing a safety or decompression stop near the surface, especially if there's a strong surge. It may range from a feeling of just discomfort to relentless vomiting that ends in dehydration and electrolyte imbalances. What can aggravate motion sickness? Certain factors do seem to predispose individuals to motion sickness, and most of us as divers may be familiar with some of them. Alcohol use the previous night is certainly high on the list, followed closely by overindulgence of food. If changing your behavior is not feasible, at least remember the golden rule to make the inevitable more tolerable. Easy in, easy out. Age has been mentioned before, and the literature would have it that the female gender may also have a greater predisposition. Sitting either at the bow or the stern of the boat, as well as certain head and eye movements such as reading or focusing inside the boat, may all aggravate the sensory stimuli mismatch. Last but not least are the psychological factors. Have you ever noticed the seemingly contagious nature of vomiting? It's not inside, it's on top, and then it's overboard. How does motion sickness actually work? We'd like to refer you to the August 2013 edition of Alert Diver for diagrams on page 29. But for now, we'll keep it simple by saying that vertigo and motion sickness are very similar, and whereas motion sickness is primarily a sensation of being off balance, vertigo is actually a sensation of ongoing motion perceived as spinning. Our understanding is that signals coming in from the eyes, the inner ear, and the body, as well as the brain, all interact and then are compared to an internal model of what should be appropriate and consistent. If there's a mismatch, then motion sickness or vertigo follows. The various components in the vestibular system allow the sensations to be detected. This is then transmitted towards the brain and synchronized between the eyes with corrective eye movements and the cerebellum and spinal cord. Various neurotransmitters, that is, a chemical that transmits signals from one nerve to another, are all involved in vestibular signaling. The one that we'll focus on is called acetylcholine, because its receptors may be blocked by certain medications, which is how it actually works and prevents motion sickness. Various components of the central nervous system are involved in regulating the stimuli related to motion. These fall outside the scope of this discussion, and we'll move on to the so-called vomiting center in the brain that is located in the brainstem. The fancy name for it is the parvocellular reticular formation, or PCRF, where the vomiting reflex is initiated and coordinated. It lies close to and is almost intertwined with the nerves that supply facial sensation and movement, swallowing as well as breathing. It is also closely related to the nucleus tractus solitarius, NTS, which in turn coordinates the so-called autonomic or involuntary functions in the brainstem. The NTS receives input from various areas and controls ultimately how these are expressed. Blocking receptors in these areas will therefore block the stimulation of and ultimately the experience of nausea and vomiting. So, what can we do about motion sickness? Let's get back to what is important to every diver. How do we prevent motion sickness? Not all methods work equally well for every diver. Some have to be combined. A small group of divers won't find any real solution without unacceptable side effects. We can divide the modalities into so-called non-medical or medical interventions. And the non-medical ones may include positioning, good ventilation on the boat, avoiding head and eye movements, and fixing your gaze on the horizon, avoiding heavy drinks or drinking of alcohol, and preparing before the dive to have all your equipment ready for smooth and rapid entry into the water. Medical modalities can be divided into the non-pharmacological and pharmacological or medication versions. The first group normally includes homemade, personal, word-of-mouth sort of remedies that don't necessarily have a significant amount of evidence, but may be worth trying. And these can include wristbands, ginger, a small meal, or a teaspoon of honey before the dive. As for medication, the following options may be effective. Hyoscine or scopolamine, of which the trade name is Scopex, is viewed as one of the single most effective drugs against severe motion sickness, but it's not readily available in South Africa. Don't confuse this with Buscopan, which is a derivative but only works for abdominal cramp. You may find a pharmacist who can source this for you from the United States or United Kingdom. It can cause visual disturbances, dry mouth and drowsiness, and it should not be taken in combination with antihistamines. The broad group of antihistamines is effective, but because they have so-called anticholinergic properties, they are also sedative. The effects may include drowsiness, dizziness, dry mouth, and blurry vision. Metoclopramide, also known as Maxilon or Clopamon, is available with prescription and is effective against moderate motion sickness. However, it can cause so-called extrapyramidal symptoms, which are involuntary and uncoordinated movements. Cyclazine or Valoid and Norzine renders a similar effectiveness, but should be avoided if you have heart problems. Good information is lacking about prochlorperazine or Stemetal in diving. A milder alternative is Cenarizine or Stugeron, which may also be beneficial. Promethazine, or Phenergan, has been found to be almost as effective as scopolamine. It is viewed as an antihistamine, but actually belongs in a class called phenothiazines. The sedatory effects can be very prominent, but what is useful is to take it the night before, allowing for a good night's rest. The motion sickness effects last, although the sedating effects have worn off. An area that is still debated is the area of phenytoin or epinephrine. It's actually a prescription drug for controlling seizures. It's not registered for an anti-seasick medication, but there's evidence that shows that it might be used safely in certain situations. For the most part, 5 milligrams per kilogram, meaning if you weigh 100 kilograms, you could take 500 milligrams a day, meaning 250 milligrams twice a day. Conclusion. Safety is the most important priority, and it also applies when using medication for motion sickness. The following guidelines should help. Always consult a diving doctor before taking medication. Take the medication well in advance and certainly for the first time prior to diving. and preferably more than 24 hours before starting a particular dive expedition. This allows you to see how it affects you. Never use a new medication just before diving for the first time, and be careful about combining medications for seasickness. Not only may that hamper the way they work, but you may aggravate the side effects. Avoid diving with medication that decreases level of consciousness and interferes with the ability to make quick decisions. As always, the Dan hotline is there to provide specialized information. Thank you for listening to this program and for supporting Dan.